Hi guys, Dr. Gillard here. Let's do some spinal anatomy. Hey, we're starting the cervical spine. What do you know about that? So finally, did the lumbar, thoracic, now we're starting the cervical. So here we go. So in general, cervical spine is made up of 7 vertebrae. There are 5 typical vertebrae and 2 atypical vertebrae, although really there's 4 typical, because C7 is a little bit strange, but I mean, for testing purposes, they're 5 typical, 2 atypical. We'll look at that C7 here in a little bit. They're designated C1 through C7. And let me get my little laser pointer here too. Oops, got my highlighter on. Yep, so they're designated C1 through C7. The top 2 are called atlas and axis, aka C1, C2. So you can need to know those words back and forth like the back. You'll be using those words like your ABCs. You have to know those. It's a very complicated system. There's actually 76 separate joints in the cervical spine. There are no ribs normally in the cervical spine. There are some new joints called oncovertebral joints, or the joints of von Luschka, that we will be looking at. And yeah, there's more movement, range of motion we've looked at a little bit. There's more motion than any other region of the spine because there's no ribs and there's some extra joints. So with all these joints, we have some very common problems. Without stabilizing ribs, we have some very common problems. Not as bad as the low back, but about 50% of people have suffered a significant injury to their neck at some point in their lives and had neck pain which lasted for at least a week. And I don't know what if means. Let me make a note. I don't even know what happened. Dragon must have knocked out a sentence there. But its job is to support the skull and brain, and like the rest of the spine, it has a vertebral canal, so its job is to protect the brain, or to protect the spinal cord as well. Normally the curve as viewed from the side is lordotic, just like the lumbar curve is. So it's convex anteriorly. It's considered a compensatory or secondary curve like the lumbar spine is. Starts forming about the 9th week of prenatal life, secondary to fetal movement. So when the baby comes out, it does have a cervical curve. It's not like it has no curve like they used to think. As the baby starts crawling, when the baby starts crawling and lifting his head up to look around, that greatly develops the curve into the thing that you have now. The curve magnitude, however, the Cobb angles are not nearly as steep as the lumbar curve is. Here's a really nice picture of this. This is a lateral radiograph of the cervical spine, and we can see we got some weird looking bones up here at the top. We got this atlas. We got this axis, the second bone. These look familiar, right? There's a vertebral body. It's got a double strutted cervical or transverse process that we'll look at with a little bar connecting them. Really strange, but we can count them. This is number 2 here. I think I actually turned these on too. Number 3 and 4 and 5 and 6 and 7. The spinous processes are bifid. This C1 doesn't have a spinous process, as we'll see, but T3 to T2 or C2 through C6 are bifid spinous process. C7 is a normal that process that sticks out, usually the farthest. Not in this patient though. T1 actually sticks out further in this patient. So the vertebral prominence would be at T1 in this patient. But yeah, that's kind of the deal. We have articular pillars here. And yeah, we have a posterior ponticle, which we'll look at. That hole is where the vertebral arteries run. So we got a lot of stuff to do, don't we? Oh, whoops, so I gotta click that one time. There we go. So 3 through 6 are quite similar to the rest of the spine, as I said. C7's kind of weird. Cramer calls it unique, but we are going to include it with the typicals. It has a very long spinous process, as I said. It's usually the vertebral prominence, which means the most prominent bump on your back. There's some more spinal basics. I think we kind of know this already, but just to refresh your memories, the motion segment is the functional unit of the spine, is the motional segment. It is made up of a vertebrae, well, you see two, a vertebrae, a disc, and another vertebrae. That is a motion segment. This would be the C2/C3 motion segment right here, or C4 and C5 motion segment. That's how you name them. You always name both levels. The disc always gets named by the bone that sits on top of it. So the C4-5 motion segment, in between that is the C4 disc. Okay. There's just a kind of a blow up of that. We're looking at the C2, C3 motion segment. What disc belongs to the C2, C3 motion segment? Who is this? Good. That's the C2 disc. The bone that sits on top of it conquers it. C2 disc. Very good. Notice there is a nice spinal cord. There's the medulla. Transforms into a spinal cord running down through the middle. There is no thecal sac. Definitely need to change fecal to, that should be thecal, right, with a T. Sorry, I just kind of made these slides up or worked on them this morning. And we get a fixed number 10. That's thecal sac. There's no thecal sac. Remember, that's only below. Usually it starts at L1, L2. What's the end of the spinal cord called? Good. Conus medullaris. Remember that stuff? Yeah, so we get a thecal sac. No thecal sac, but we do have a spinal cord. Very delicate, needs protection. Typical parts. These are the parts we're going to be learning. We'll be going over this as we kind of go through here. But of course, we have a vertebral body. There's the vertebral body right here. We have a bony end plate. Right here's the bony end plate. These are new, right? Look at these weird things. These are Batman ears. We'll talk about them more specifically. But those stick up from the vertebral body. And that's our extra set of joints. These are part of the members of the joints of von Luschka, or the oncovertebral joints. So you definitely need to know those, because we can get bone spurs and all sorts of trouble. I think I'll show you one of my patients who had trouble with that. So those are called the uncinate processes. There's also two facets down here, one on this side, the other you can't see. Those are where the bottom bone uncinate processes connect. Those are called the facets for the uncinate processes. There's two pedicles which connect. The pedicles would be right about here. I'll show you a better picture of that in a minute. But yeah, that's vertebral arch. Can't really see the arch that well from this image. Two articular pillars. You can see the whole articular pillar quite nicely right here. Same kind of deal. The articular pillar has three parts. In the very center, let's see if this will work. Oh yeah, very cool. In the center is the pars articularis. This is the superior articular process. This is the inferior articular process. Here's a facet of the inferior articular process right there. Forms part of the zygapophyseal joint. Can't see the other facet from this view. Lamina is over here. Kind of hard to see. We'll see a better view of that in a minute. Okay, double strutted, really weird transverse process, or double barred. Standring likes to call these bars. I don't think Cramer actually weighed in on these, the names of these. Could be wrong, but I like to call them struts. There's an anterior strut right here, but you can call it the anterior bar. And then here's the posterior bar. Off these bars, we have these little knobs. Those are called the tubercle. There's the anterior tubercle. There's the posterior tubercle. We have a piece of bone. Make this orange. We have a piece of bone in between here. And it's in between the tubercles. So it's called the intertubercular lamellae. Intertubercular lamellae is that piece right there. There's a transverse foramen that you can see. The vertebral artery goes through there. It's got a kind of a wicked deep superior vertebral notch, doesn't it? Look at that thing. Made by the Z-joint, superior articular process, and the uncinate process. We'll talk about that more when the time comes. I think I got all the parts on this slide. This anterior tubercle can be really big at C6. In fact, it's so big, you can give you a really good idea. Like if you're a surgeon, the PA always comes in and pokes around for this thing and then puts a line there so the surgeon has an idea where he's at and where to start. But that big bump, that's called the carotid tubercle of Chassenec. Chassenec. Sha like shatter. Chassenec. Okay, carotid tubercle of Chassenec. Got it? Right, and here is a CT, couple patients of mine, CT scans. We have, what is this, lumbar? You tell me. It's got to be lumbar, right? The transverse processes are sticking right out from the sides like airplane wings. But look at this weird design. Transverse processes are going, they're going more at an anterior 45 degrees, right? There's a spinous process still in the back. So this is the front. Yeah. So that's the deal. There's the double struts, or the anterior bar, posterior bar. So very, very weird. Got a nice big neural foramen here. Or vertebral foramen, sorry. Okay. Here is a patient of mine this year. What's that thing? That's an ACDF. We'll look at that type of surgery. That's the Peyton Manning surgery. It's also a myelogram, right? You can see the thecal sac is filled with contrast. You can see the spinal cord. There's the anterior root, posterior root there, or the dorsal sensory root and motor root. But the point of this slide is to show you there is that carotid tubercle right there. See how big they are and prominent? This is C6. Okay, back to the main parts. Bifin spinuses, we've looked at that. Vertebral foramen are kind of difficult. This is forming the part of the vertebral foramen, and the bone below would come down and form the other half of it. So there is a vertebral foramen, and there's a transverse foramen too for the vertebral artery. So that's a little weird. All right, so this is, I think this is on your lab worksheet for tomorrow. It's got all the parts. You can't see the little Batman ears sticking out of the plane of the page, but these are coming right up like we saw out of the plane of the page. So those are the uncinate processes. Vertebral body is here. You could call that the superior bony end plate if you want as well. Superior bony end plate, depending if that choice is available. Here is the vertebral foramen in the center, number 10, of course. Guys know that. Now we can see the lamina really nice. Really big, thin lamina on each side. There's the lamina. Spinous process is right here. It's a bifid spinous process, so it's like a pitchfork or a tuning fork. See how it's double strutted? That's a bifid. That's all spinous process property here. We'll call, let's say, spinous process actually goes into here. The two lamina fuse, they melt into the spinous process here. These are hard to see, but these are the articular pillars. Kind of hard to see from this view, but we can see the double strutted transverse process quite nicely. So there's the anterior strut or bar, number 15. Number 16 is the posterior strut. The tubercles are not super prominent, but there's the anterior tubercle. And the posterior tubercle is not really that visible. Intertubercular lamellae is right here. And then we got the pedicle would be right here, number 12. It's all pedicle property. There's also a groove right here for the ventral ramus. That's going to go down and form the brachial plexus. Remember, have you started that yet? Because you got to know that for gross 1. You got to know that for me as well. You won't have to. Maybe I'll have some cadaver pictures on the final lab exam. So you got to know that brachial plexus. All right, I think we got all the parts, and there they all are for you to practice on. That'll definitely be on the final. The lab final. Maybe even, I'm showing to you in class, so it could be on both. All right, now let's look at C7 again. We already said it's weird. There's no bifid spinous process here. We've already went over all these parts, but it still has the double-strutted transverse processes, yet it doesn't have the double pitchfork spinous process, which is a little bit weird. There's the lamina. I don't need to go over all these parts again. But yeah, it's typically the vertebral prominence. But let's quantify that. 75% of the time, it sticks out further than T1. Now, I just showed you an X-ray where that wasn't the case. 15% of the time, T1 sticks out further. I really question, for testing purposes, those are the numbers from Cramer. I really question whether that's true. To me, it seems like T1 is at least 50-50, but I don't know. That's just my own personal experience, so better stay with 75% of the time at C7. T1's only 15. Occasionally, it's C6. 10% of the time, it's C6. That'll be one of your goals in lab, is to palpate that spinous process and identify the vertebral prominence. They'll teach you how to do that by palpation. C7, it sits at the base of the neck. Lots of muscles attached to that spinous process. Trapezius, rhomboids, and the tubercles, right? The anterior and posterior tubercle, the scalenes, the anterior and posterior scalenes attached to those. And there's multifidi thoracis attaches into those things. So there's a lot of muscles that attach to those. You're going to learn those muscles in lab, so I don't have to go over muscles very much. Some fun facts about C7 again. The anterior tubercle is really, really small, which is strange because C6 is so big. Posterior tubercle is huge, and in some of them. So it also has a tiny transverse foramen. Where do we have a real picture of it? Yeah, I guess that does. I'm thinking it could be C6 too. But yeah, the picture's probably better. It's a tiny little foramen here for it. That's probably C6. So that's just kind of a freak. I don't think that really is C7, come to think of it. But we'll use it for whatever's on these slides is the law for testing purposes. Yeah, but you can see how the transverse process doesn't look as double-strutted, even though it can be double-strutted. Okay, what else? Smallest transverse foramen, we just showed you a picture of that. Vertebral artery, very weird. The vertebral arteries don't usually go through. Even though there's a transverse foramen, vertebral arteries don't use it usually. But the vertebral vein does use it. So that's weird. Anything there's something weird like that, that's always a good question from boards and from me as well. So vertebral vein uses it. Transverse processes may be elongated. In some cases, we'll look at thoracic outlet syndrome here, which is a terrible name because it's really the thoracic inlet that they call it the thoracic outlet. Don't get me started on that. So they can become elongated or hypertrophic, or they can grow ribs off them. So that's really strange. I think I mentioned that. Let's look at a case. 37-year-old electrician comes into your office complaining of neck pain and this weird burning and tingling that goes down his right upper extremity, especially into the pinky and the ring finger. You take some radiographs. Let me show you what normal is. We didn't look at this angle yet. Here's an A to P view of the spine. We looked at a lateral view. And we can see, what do you think these things are right here? It's that weird first rib, isn't it? And it's connecting to, there's the costal transverse joint would be right here. So this must be T1. And this is C7. If you blow up C7, there's C7 again. Actually, let me use the C7. You can see its spinous process is right here. C6 spinous process is here. Notice the shadow. This is the trachea shadow. See the shadow going down? It's anything that air lets photons go through. Make sure you watch that cervical YouTube video on how to read your cervical x-rays, because I do test on that. I forgot to test you on that on the lumbar, but I'll get you on cervical. But the point of this is, here's the transverse process of 7. And the point is, that's C7. Did I say 6? It's not 6. The point is, their T1 transverse processes come out further, and that's normal. Okay? If these come out, let's see, can I erase that? Yeah. If these were to come out like this, which you'll see, those are called hypertrophic transverse processes. Those aren't a cervical rib. Those are just elongated hypertrophic transverse processes. You want to see our patient? Let's take a look at our patient. Oh, yeah, you guys can see it, huh? So are these hypertrophic transverse processes? Yeah, they're actually hypertrophic. And is there a rib attached? Yeah, there's a rib attached as well. So here's the transverse process. Right? Does it go out further? There's T1. There's T1 on this side. Does it go out further? Yeah, it does. So it's hypertrophic, and let's change up the colors. And it has this weird thing. It's got a rib. Okay, so that's called the cervical rib. And this is an example of hypertrophic transverse processes, which gave rise to a cervical rib. So that's pretty cool. Right? So why does he have pain? Well, brachial plexus is right here. Right? There's C8. So this is crushing the between the scalenes, the anterior and medial scalene, and this rib. It's compressing the C8 and T1 roots of the brachial plexus, and it's probably got the inferior trunk as well. So that's why he's having trouble. I mean, if it's really bad, they have to go in there and surgically try to remove this. Very kind of delicate surgery, right? Because you got brachial plexus is really a delicate little beast. Okay. So hypertrophic transverse processes and cervical ribs. You don't see that often. Thoracic outlet syndrome. So you get a compression of the brachial plexus, usually the lower roots, usually C5 or C8 and T1, and maybe the lower trunk as well. But you get a compression of that as well as the subclavian artery. They both go through something called the scalene triangle. Subclavian vein does not. So if you get hypertrophic transverse processes and or a cervical rib, you're at risk for thoracic outlet syndrome. How does it present? With pain in the ulnar nerve distribution, going down your karate chop part of your hand. That would be the medial part of your hand, and the little finger and the ring fingers, where you get pain and tingling and numbness and all kinds of weird stuff. pec minor tendon can sometimes cause thoracic outlet syndrome as well. You'll have plenty of classes on that. You have, I think Dr. Feinberg will talk to you about that when you get, I forget what quarter, I think either 4th or 6th quarter. But yeah, you'll learn about that because you're going to have patients with that problem. And they have neck pain, they have radicular pain. Remember, that's pain in a dermatonal distribution, so it's usually in the ulnar nerve distribution. And they'll have radiculopathy. They'll lose their C7, their triceps reflex. They'll have numbness over the ring and middle finger. All right. So this thing you need to know. Make sure you know the brachial plexus. Rick Taylor drinks Coors beer. Rick Taylor drinks Coors beer. So here we go. Roots. C5 root, C6, C7, C8, T1. That's the roots. These roots are nothing more than the ventral rami of the cervical spine, which we just looked at. Right? There's a spinal nerve. It splits into a ventral and a posterior rami, just like before. So these are the anterior ventral rami, C5, 6, and 7. I won't worry about the little things that come off it, like the long thoracic nerve, which you'll be able to see on the cadavers quite nicely. And the pesky, I call it the pesky. This thing is always trouble. The word dorsal scapular is just trouble, so I call it the pesky dorsal scapular nerve. But don't write that in your test, which I had somebody do last quarter. It's the dorsal scapular nerve comes off this C5 root. It actually comes off the trunk here in this drawing. One thing you'll learn when you look at brachial plexuses, I don't think you'll see one that looks perfectly like it does in the books. They'll look similar, but they're all different. So there's quite a bit of anomaly in the brachial and the lumbosacral trunk, or in the sacral plexus as well. But I digress. So we have roots. Okay, 2 roots come together. Well, not 2, but C5 and C6 roots come together to form a upper trunk or superior trunk. Won't worry about that little twig there. Right? C7 root morphs into the middle trunk. There's no combining of anything. Where the C7 root starts and the trunk begins, it's kind of arbitrary. You just kind of eyeball it. The inferior or lower trunk is made by the C8 and T1 roots. So far, really, really easy. There is one coming off. The suprascapular nerve is really important. That comes off the upper trunk. I said I wasn't going to talk about those. That's Dr. Zhang's territory, though. All right. So easy so far, easy peasy. We got just 3 structures. These structures are going to split in 2. Okay, each one of them. Let's change my color here. How about green for this one? So the superior trunk is going to split into an anterior division. Rick, Taylor, now we're on drinks. We did Rick as the roots, T is for trunk, drinks is for division. So the trunk splits into the anterior and posterior division. These posterior divisions can be crazy anomalous. Some of them are super short and stubby. Some of them are really ridiculously long, but they can be really anomalous. That's why the author made it a little darker here, to show that this is sinking into the plane of the page. And these anterior trunks are more out of the plane of the page. Okay, middle trunk morphs into, guess what? An anterior and posterior root. What if there's a pin stuck in this? Anterior root of the middle trunk, posterior root of the middle trunk. Right? There's posterior. So the lower trunk splits into a posterior and anterior division as well. Got it? Trunks split into divisions. Divisions are going to come together now. Okay, so we're done with divisions. Now divisions, let's pick another color. Better go with red. Divisions, now we're going to get into three really important structures. So the upper anterior, or the anterior division of the superior trunk and the anterior division of the middle trunk form this very important structure, right? That's the lateral cord. You always start to look for the lateral cord on the cadavers. You look for the M, actually. We'll get to that in a second. All right? So now, just like the C7 root formed the middle trunk, the anterior division of the lower trunk gives rise to the medial cord. Got it? These two cords all these cords are super important. So now, check this out. The posterior divisions of all trunks give rise to the mighty posterior cord. Got it? Posterior cord was born from the posterior trunk, or posterior division of the upper trunk, the posterior division of the middle trunk, and the posterior division of the lower trunk give rise to the posterior cord. So now we got our three cords. Our three cords are now going to, and cords is Coors beer, right? We're in Coors beer for cords. And now the branches. These are like the terminal branches. So let's start with lateral. These are really important nerves now. We'll follow these all the way down, some of these all the way down into the hand. So the lateral cord gives rise to the musculocutaneous nerve. Okay, musculocutaneous nerve. It also gives off half of the contribution. Here's the contribution to the medial or median nerve. So it gives off a branch. You can call it contribution to the median nerve. Okay, so it's the lateral cord contribution to the median nerve is this guy right here. Pretty mean for lab instructors to pin that because you have to write that in. It doesn't even fit in the space very well, but they could. Let's save the posterior cord. Medial cord also splits into two main pieces. It splits into the ulnar nerve, and then it splits into its contribution. So here's the median nerve, or the medial cord's contribution to the median nerve. Be careful with that. So this is right here, the medial nerve's contribution to the median, not medial, median nerve. Got that? All right, awesome. Let's go through just a couple branches I want you to... let's go through the posterior. What about this mighty posterior cord? It's going to split into a big, thick nerve called the radial nerve right there, and then an axillary nerve right here. Those are its divisions. Right? I'm only going to ask you two more, because you got to know these because they're clinically important. Let's see. Let's use the light blue. Did we use this? I can't remember. So we have two nerves right here, and they both go down to the medial part of the hand, forearm, and arm. So the one that goes furthest, and these can vary too. They can be, sometimes they have a common trunk, and they do like a snake tongue here. These have two trunks. I've seen them coming all the way back down here off the anterior division. I've seen them coming way back down here off the trunk. So they're very anomalous where these guys come off. But this one, the one that goes the furthest, okay, crosses the elbow. If you cross the elbow, you're into the antebrachial territory. Okay, so that's called the medial antebrachial cutaneous nerve. And that gives rise to your C8 dermatome. So you can test that with your little pizza cutter, your little Taylor pinwheel, or however they're teaching you to test it these days. That's T8. Right? And then this one, it doesn't go as far. This nerve doesn't cross the elbow. And these are both cutaneous nerves. They plug into the skin, not muscle. So this one is called the medial brachial cutaneous. Why brachial? Because it doesn't pass the elbow. Why antibrachial down here? Because it passes the elbow. That's C8. This is T1. Oops. All right. So you better know this picture. Something like this will be on the test. I might even have a cadaver picture on there. So make sure you know that. I've completely lost track of my time. So let's see. This is only 50 minutes. I think we should be good. So everything I just said, there's the roots, there's the trunks, the divisions, there's the branches. You got to know all this stuff that I just went through. Okay, here's a real cadaver specimen. I think you probably started looking at this by now. This is an A to P view, so we're looking anterior. Here's the clavicle right here. And you can see a very nice dissection. There's the T1. These are all the roots, C5, C6, C7, C8, T1. You can also see the medial scaling is behind this thing. So that meat underneath there is the medial scaling. Okay, the anterior scaling has been pushed back because usually the anterior scaling is like coming down like this. So they kind of push this back. There's ansa cervicalis, there's the wishbone. Anyway, I'm digressing. Clavicle is right in here. And so, yeah, so we can see, look at that. The roots of T1 and C8 come together to form trunk, right? Lower trunk, inferior trunk, or lower trunk. There's the middle. Remember, nobody helped the middle C7 root. Just morphed into the middle trunk by itself. And there's C5 and C6 morphing into the upper trunk. And then we're losing it. We're losing it where they split in divisions. But alrighty, so I think that's probably enough for today. There's my wonderful Photoshop skills. And notice how the roots and trunk were sandwiched between the anterior middle scaling. Yeah. Okay, that's a great place to stop. So we'll pick up with the vertebral artery next time. Actually, don't forget now you have your test. There's no next time this week. Week 7, we're taking our test on Wednesday morning, so no lecture. All right, see you later.